Chapter 100 Mucoceles of the Paranasal Sinuses. Definition: a mucocele is an epithelium lined mucus filled sac within one of the paranasal sinuses with expansion of the sinus cavity and remodeling of the sinus walls. It forms secondary to obstruction of the outflow tract of the involved sinus together with an inflammatory process within the sinus. It is lined by pseudostratified or low columnar epithelium in contradistinction to a cyst that has a distinct separate membrane. Where bony erosion has taken place, the mucoceles epithelium is often fused with dura or orbital periosteum. Sites of development: the frontal, ethmoid, maxillary, and sphenoid sinuses are involved in descending order of frequency. Frontal sinus mucoceles are probably more common because of the complex and narrow drainage pathways of the frontal sinus that is easily obstructed. Mucoceles can form in any other aerated structures such as a concha bullosa of the middle or superior turbinate. Obstruction of the nasolacrimal duct can also cause a lacrimal sac mucocele or dacrocele mucocele with a concha bullosa. Etiopathogenesis of mucoceles: series, number of cases, prior sinus surgery, prior trauma, spontaneous, chronic rhinosinusitis without surgery, tumors. Etiology: sinus surgery is now the leading cause, 66 to 86% of mucocele formation following surgery, mostly for chronic rhinosinusitis and nasal polyposis. The interval between surgery and subsequent mucocele formation can range between 1 and 19 years and depends on the location of the mucocele, with frontal and sphenoid mucoceles developing earlier than maxillary sinus mucoceles. Surgery in the area of the frontal recess during functional endoscopic sinus surgery can cause circumferential injury to the frontal sinus outflow tract with subsequent stenosis and mucocele formation. External frontoethmoidectomy or Lynch-Howard's operation is a leading cause of mucoceles because of loss of lateral bony support of the frontal recess, which causes herniation of the periorbital tissue into the frontal sinus outflow tract. In a large series by Blockmull et al., 78% of mucoceles following sinus surgery was associated with the Lynch-Howard and or Cadwell-Luke operations versus 1.5% after endonasal surgery. A significant incidence of mucoceles has been reported following endoscopic repair of skull-base fractures in children. In one study, 50% of patients developed mucoceles after repair of skull-base defects with a middle turbinate overlay patch. Only 10 to 14% of mucoceles are secondary to trauma and 15 to 17% develop spontaneously. The mean interval between head injury and mucocele formation is 9 years. Any benign or malignant tumor can lead to mucocele formation, but the incidence in the literature is low and ranges from 1 to 5%. Pathogenesis: it is thought that in the order for a mucocele to form, two factors are essential: an obstructed sinus outflow tract and an inflammatory process within the sinus. Osteolytic cytokine IL-1 and tumor necrosis factor are present within the epithelial lining of mucoceles. It has been postulated that this cytokine may be responsible for the bony erosion in expanding mucoceles. Clinical features: bony erosion leads to expansion of the sac beyond the sinus cavity into the cranial cavity or orbit. Symptoms depend on the sinus involved. Visible mass is often seen on the forehead, medial canthus, or in the gingivobuccal sulcus or cheek. Ophthalmologic symptoms are more common than rhinological and neurological symptoms. The most common ophthalmologic complaint are periorbital swelling, pain, and exophthalmos. Displacement of the orbital contents can lead to limited ocular mobility, visual disturbance, and diplopia. Optic neuropathy has been reported in up to 18% of patients who present with ophthalmologic symptoms and is due to direct compression of the optic nerve in the posterior ethmoid and sphenoid sinuses. A mucocele within a concha bullosa may present with nasal obstruction and or a secondary sinusitis. Epiphora and a cystic swelling in the medial canthus suggests the presence of Mucoceles. Site of involvement, according to the series, number of mucoceles: frontal, frontoethmoidal, ethmoid, sphenoethmoid, sphenoid, maxillary. Radiology. Computed tomography CT findings suggestive of a mucocele are a homogeneous isodense lesion within an expanded sinus with bony remodeling of the sinus walls. Contrast enhancement only occurs with a pyocele. A bony defect of the lamina papricea and or superior medial part of the orbital rim is often seen in the frontoethmoidal mucoceles. The globe may be displaced laterally or inferiorly with evidence of proptosis on axial images. The sac can cause erosion of the posterior table of the frontal sinus and compression of the intracranial contents. It can be difficult to differentiate maxillary sinus mucoceles from other benign or malignant lesions. This is a figure 100.2. Frontal sinus mucocele with cosmetic deformity of frontal area. A is the sagittal view, B is a coronal view, C is the expanded frontal sinus with bony remodeling of both orbits and frontal sinuses. D is sagittal view of frontal sinus mucocele showing bony remodeling. E is MRI variability due to the difference in mucocele contents. F is axial T2 and G is T1 MRI of the patient. Magnetic resonance imaging MRI should be considered in cases of significant bony erosion of the posterior table of the frontal sinus or the orbital lamina papricea in order to delineate the mucocele from adjacent soft tissues, example cerebral tissue. It should be recognized that MRI can be misleading due to the variability of mucocele content. Mucoceles generally have high water content and are hyperintense on T1. Pyoceles have high protein content and greater variability of signal intensity on both T1 and T2 weighted images. Displacement of the left eye secondary to frontal mucocele, sinus mucocele. B is a coronal section of the CT scan of the patient. Differential diagnosis: benign or malignant tumors, allergic fungal sinusitis or other fungal disease, cholesterol granuloma, which is rare. Surgical management: treatment is widely marsupialize the sac to provide permanent ventilation and sinus drainage and to relieve pressure on vital structures. Cosmetic deformities often settle with time as bony remodeling takes place. Frontoethmoidal mucoceles, wide marsupialization is essential whether by endoscopic and or open technique. Endoscopic surgery with wide marsupialization and nasalization is the first line of treatment for simple mucoceles. But a modified endoscopic Lothrop procedure (MELP) is often required for more complex frontal sinus mucoceles. Good results have been reported with endoscopic techniques with recurrent rates ranging from 0 to 25%. The MELP is especially useful whether there is loss of lateral support in the frontal recess due to the bony erosion or previous removal of the superior aspect of the lamina papricea. Combined approaches are often required for laterally located mucoceles, as thick bony septations might not allow for endoscopic techniques alone. Whilst the Lynch-Howard's approach can be used to access laterally located frontal sinus mucoceles and to assist with the drilling down of bony septations, and the approach is associated with risk of long-term frontal outflow obstruction and osteoplastic frontal flap in combination with MELP may be required for those mucoceles lying far laterally in the frontal sinus. Transorbital neuroendoscopic surgery, TONES, tones, and specifically the superior eyelid approach allows for an alternative, less invasive approach to address pathology of the lateral frontal sinus. Stenting remains controversial. Most authors do not advocate the use of stents to maintain patency, especially in smaller unilateral marsupializations. If a stent is placed, it is important that it is loose fitting to prevent circumferential pressure necrosis that could eventually lead to stenosis. Obliteration of the frontal sinus has a high success rate, 93%, but a major complication rate in excess of 20%. A contraindication to frontal sinus obliteration is extensive erosion of the posterior table of the sinus due to inability to remove the normal respiratory epithelium on the dura. Obliteration has therefore largely fallen out of favor. Maxillary mucoceles. It is important to allow for wide drainage of the maxillary sinus into the nasal cavity. A wide medial meatal antrostomy will usually suffice. A partial medial maxillectomy with preservation of the lacrimal system may be required to gain access to laterally located mucoceles. The Carvel-Uke approach is only offered in centers where endoscopic surgery is not an option. Sphenoid sinus mucoceles. A wide sphenoidotomy and intranasal marsupialization are all that is required for sphenoid sinus mucoceles. No attempt is made to remove the lateral sphenoid sinus mucosa, as bony erosion places the internal carotid artery or optic nerve at risk of injury. Other mucoceles that have formed within a concha bullosa require resection of the lateral aspect of the concha bullosa. Dacroceles are managed by endoscopic dacrocystorhinostomy. Complications. Great care needs to be taken when decompressing a large tense frontal mucocele that displaces the frontal lobe of the brain, as sudden expansion of the cranial contents can disrupt the dural vein vessels and cause a subdural hematoma, or disrupt the dura and cause a cerebrospinal fluid leak, CSF leak. Close post-operative monitoring is therefore essential in such patients because recurrence can occur decades later. Long-term follow-up is required. Homogeneous isodense lesion within an expanded ethmoid sinus with bony remodeling of the sinus wall. Best clinical practice. CT is the imaging modality of choice and must be performed preoperatively. Wide endoscopic marsupialization is the first line of treatment for simple mucoceles. MELP is a good alternative to obliteration procedures. Combined approaches may be required with laterally located frontal sinus mucoceles. Long-term follow-up is required to assess the need for further surgery to correct cosmetic deformities and to ensure patency of the marsupialized sac. Further research, the pathogenesis of idiopathic mucoceles needs to be further investigated to ascertain if factors exist that makes certain people more susceptible to mucoceles. Although cosmetic deformities can settle with time as bony remodeling takes place, no studies have been done to assess the long-term cosmetic outcome with marsupialization alone. Key points. Sinus surgery is now the leading cause of mucoceles. Wide marsupialization is required for all mucoceles. Bony remodeling can take place after surgery and cosmetic deformities will improve with time. Thank you.